And now I'd like to call for Dr. Wexler, that I also have something to say, because I met you for the first time last night. And I was so tired before I met you. And when I got home, I was so energetic because you have so much inspiration in your work. So thank you so much.
Thank you. But before I get into the medical part of this, when Oded asked me a few months ago, I think it was in February, if I would consider coming to speak with my colleagues and with families of children with cancer, it was a very simple yes, not only because this caring for children with cancer is my passion, but because I thought it was critically important for American Jews to express their concern and solidarity with our brothers and sisters and cousins here after the events of October 7th. So I want all of you to know that we are thinking of you every day. We share your outrage at the hypocrisy of the world in pointing fingers and saying, lay down and let them cut your throats and do nothing about it. And I hope that my participating in this conference will be helpful to families, to you. And I would start by saying that the title of this talk is actually slightly misleading, because the question of caring for children with rare tumors, how do you define benefit and who gets to decide? It's not only true for children from overseas. So I have the tremendous privilege of working at a very large cancer center in New York City. And working at a cancer center is different than working at a children's hospital. The singular focus is the treatment of cancer. We don't compete for resources with pediatric cardiology or pediatric neurology or pediatric infectious diseases or a neonatal intensive care unit. Everything that exists in that environment is dedicated towards the treatment and eradication of cancer. So these are conversations that I have every day with families of children who don't live in New York City, families from New Jersey, from Pennsylvania, from Connecticut, from Florida, from California. Would it benefit their child to relocate to New York and come for treatment? And I've tried to select a few cases, a few examples, to put you inside my head to how I try to answer these questions. And I would just add, on a personal note, unfortunately, my family has lived through what many of you are going through or have gone through. I had a baby nephew, my first nephew, who died on his second birthday, 4 weeks after being diagnosed with cancer. My sister was blessed with 2 other children after that, one of whom, from the minute she came out of the womb, was a firecracker. And she told me at the age of 5 that she was going to become a pediatric cancer doctor so she could cure cancer, so nobody else would die like her brother did. And she asked if she could come to camp with me. Like Dr. Fine-Levy, I had the privilege of working at Camp Simcha, and I told her, Zoe, you can, but you have to be double digits. You have to wait until you're 10. So when she was 10 in the summer of 2009, she came to camp with me for the very first time as my assistant. She would pull charts for me. She would file things for me. She was very bright. And she would come work in the infirmary with me in the morning, and then she would do activities with the campers in the afternoon. And then at night, she would go back to the bunk and wait for me to come back from evening infirmary hours so I could give her a science lesson. She's very, very smart. She's very smart. And I would teach her about things like mutations and fusion genes and how chemotherapy worked. And after a couple of days of this, she said to me, Uncle Lenny, I really, really want to be a pediatric cancer doctor. What's the most important thing for me to be good at? Do I have to be good at science? Do I have to be good at math? Do I have to be a good writer? I said, sweetheart, you have to be good at 2 things. And she sort of thought about it, and she said, only 2 things? I said, 2 things. And what are those 2 things? I said, you have to have a good heart, and you have to be a good actor. And she thought, she was a very deep thinker, and she said, Uncle Lenny, I understand why I have to have a good heart. Because I have to care about people, I have to have compassion for them. If they're suffering, I have to recognize that and support them. But why do I have to be a good actor? And I said, because there are going to be a lot of days, if this is what you do, where you're going to walk into the first room and you're going to have to tell a mother and father the one thing that no mommy and daddy ever wants to hear, which is that their child is going to die and there's nothing you can do about that. And then you're going to go to the sink and you're going to wash your hands off and you're going to walk into the next room with a mommy and daddy whose child has just been diagnosed with cancer. And you're going to have a smile on your face, and you're going to tell them that everything is going to be okay. And in the time that it takes you to walk out of that first room and into the second room, you have to pretend that nothing ever just happened, because that's your job. But those conversations take a toll on you if you're human. And you have to figure out how to figure out who are the patients you can help and who are the patients you can't help. So I like to tell stories. I come from a long line of storyteller Galiciana Jews. So the first story is about a 10-month-old baby with a 6-centimeter tumor arising next to her spine. She had a scan that seemed to suggest that her cancer had spread into nearby lymph nodes. Her biopsy showed a very rare type of rhabdomyosarcoma. To try to put this into context for you, the US is a country with 330 million people. There are 100 children diagnosed each year in the United States with fusion-positive rhabdomyosarcoma, and there are 25 out of those 100 who have this type of fusion-positive rhabdomyosarcoma. Israel is a country of maybe 10 million people. So if you do the math, there is perhaps 1, but no more than 2 children diagnosed each year in Israel with this type of rhabdomyosarcoma, and perhaps once every 4 or 5 years in a baby under a year of age. In the course of trying to figure out whether the cancer had spread anyplace else, she had what's called a bone marrow biopsy, which was thought to show the spread of cancer into her bone marrow on the left. And she began treatment with a European chemotherapy treatment protocol, which at that time required that babies under 1 year of age be given 50% doses of chemotherapy. And at that point in time, her family made contact with me. I got a phone call from someone who introduced himself to me. He asked if he could speak with me about his baby niece. I asked him where in New York he was staying. He was actually staying about 3 minutes from where my wife and I lived. I told him to meet me on the corner at 7 o'clock in the morning, and I would drive him to work with me, and we could talk about his baby niece. And on a pouring, cold, rainy morning, Tuesday morning, I picked him up at the corner of West End Avenue and 70th Street. We drove in my little red sports car across town to the hospital. We spoke about his niece. He asked me if she should come to New York, and I told her I thought that he should, that her family should, because I thought that her surgery was going to be very complex, and that the kind of radiation therapy that she would need would really be best given at a center like ours. Unfortunately, it wasn't possible for them to come immediately after treatment started, but we hoped that we would see them in time for surgery. Repeat scans were done after 3 cycles of chemo, which showed improvement. And when they got to New York City, as you already heard from Oded, her cancer had gotten bigger. Surgery was off the table. I told her parents that we needed to shift gears, that despite what they had been told in Israel about it not being possible to treat a baby her age with more chemo or with stronger chemo, it was very possible. We do it every day. And I hoped that she would respond, or her tumor would respond well enough that she could undergo successful surgery. Thank God, after a few months of treatment, as you heard, on May 20th, 14 years ago, she underwent successful surgery. The tumor was removed in its entirety, but was still predominantly healthy, despite the intensification of chemotherapy. Fortunately, all of the lymph nodes that were sampled were negative, and with the benefit of a little bit of time and retrospective vision, we could figure out that it was an overcall of the initial imaging, that her tumor had not really spread to her lymph nodes, and that the positive bone marrow was not really a positive bone marrow, but actually a biopsy through the tumor when they were doing the bone marrow. After her surgery, she continued with very toxic chemotherapy. If you ever meet a pediatric oncologist who says the word, "Oh, it's not such bad, the chemotherapy," run away. It's horrible. It's horrible. We don't like to use it. We hate giving it. But right now, it's one of the only tools that we have. She had postoperative chemotherapy and postoperative radiation therapy. This is Shani. This is Perchi. This is me at a Chai Lifeline retreat, if I remember correctly. And thank God, things turned out well. Was this international consultation and relocating your family worth it? I think so. Let's talk about the second case. This was a 16-year-old young woman who was diagnosed with a large pelvic chondrosarcoma. And again, to put things into context, this year in the United States, a country of 330 million people, 50 kids will be diagnosed with chondrosarcoma. Do the math. Divide 50 by 33. 1 or 2 patients in Israel will be diagnosed with chondrosarcoma. A biopsy was done here. The doctors here, because it's so rare, had trouble interpreting what they were seeing. They sent it to a pathologist at the University of Miami who reviewed it and felt that it was a low to intermediate grade chondrosarcoma. There is no such thing as a low to intermediate grade chondrosarcoma, but that's what they thought. She underwent surgery. The surgery was thought to have removed all of the visible tumor, but to likely have left behind microscopic disease. And so her surgeon recommended that she come to New York to get radiation therapy at the proton beam facility in New Jersey. To his great credit, a statement that I don't often make, but to his great credit, Rabbi Führer advised the family, before you leave for New Jersey, you should tell the doctors to do another MRI, just to see how things look. They did the MRI. It was interpreted by the radiologists here as showing post-operative changes. They came to New Jersey, and she started radiation therapy about 2.5 months after surgery. I got a phone call about 2 weeks into her course of radiation that she seemed to be having new symptoms that the doctors couldn't explain, and would I be able to see her? I did. We reviewed her pathology. It was a high-grade chondrosarcoma, a more aggressive type of cancer. We reviewed her imaging, both the August study that had been done in Israel and an MRI that I got that day, and it showed that the tumor had not been removed in its entirety, that when she left Israel at the end of the summer, there was still a quite significant mass, and that it had been growing despite the 2 weeks of radiation that she had. About 4 weeks later, because she couldn't go for surgery immediately, her skin was so inflamed from the radiation that it would have been unsafe. About 4 weeks later, my colleague Patrick Boland, working in combination with one of our plastic surgeons, performed, if I remember correctly, I think it was an 18-hour surgical procedure. I may be off by a little bit, but not by very much, where he removed the tumor from the pelvis, and a bone was taken out from the lower leg and replaced into the pelvis. This is a process that is done in other parts of the body relatively commonly at our institution, almost never very many other places. It takes roughly a year for the bone that's taken from the leg to become a new pelvic bone, but it becomes a new pelvic bone. And she remains free of any evidence of cancer more than 10 years out from her surgery. It gets better. This is Shachar with my mom in December of 2015 in the lobby of the Inbal Hotel. It gets better. This afternoon, she qualified to represent Israel in the 2024 Paralympics. Was it worth coming overseas to pursue treatment? I think in this case also, yes. Was it of benefit? Pretty clearly. The next case is one that I struggle with. I don't have the answers, right? A good teacher is not supposed to have all the answers. They're supposed to ask the questions. This was a remarkable 21-year-old young man, the kind of kid that you fall in love with. You meet him and you fall in love with him. The most difficult part of treating this kid was keeping the nurses off of him. Like, every nurse wanted to take care of him, right? Because he was beautiful and they all had crushes on him. So this young man was diagnosed in November of 2017 when he was 17 years old with incurable cancer. It needs to be emphasized. There was no possibility that he was going to survive his disease. It was certain that he was going to get better. It was likely that his cancer was going to go away, but there was no possibility in November of 2017 that he was going to survive his cancer. It was certain that it was going to come back. His cancer had spread all throughout his body, and as predicted, it got better and it went away. In August of 2021, when he was 21, his cancer relapsed. It probably relapsed at the original location in his left thigh. It spread into lymph nodes in his pelvis. The doctors in Israel formulated an absolutely perfect treatment plan. I want to emphasize this. It wasn't wrong, it wasn't inappropriate, it was exactly what I would have recommended. And I said to the family, don't come. I have nothing different and nothing better to offer you. I got a phone call from one of my colleagues who works with Dr. Fine-Levy. Lenny, they want to come. I said, Mark, tell them not to come. I have nothing different to give this kid. About a week later, I get a phone call. Dr. Wexler, there's someone here in New York who says he has an appointment to see you. You should know this is only something that Israelis do. I said, who is it? told me his name. I said, I told them not to come. And she said, well, what should I tell them? I said, tell them I'm about to leave on vacation, but I need to see him. So they're here in New York, and they want to be seen, and we see him. But it's now been over a month since his last set of scans, and now he's got back pain that he didn't have when he left Israel. So we repeat his scans, and it shows that in addition to the tumor that we knew about in his thigh and the lymph nodes in his pelvis, he also has had cancer spread into the bones of his spine. And we start a fairly standard chemotherapy regimen, which he gets 6 cycles of over the course of 4 months, with significant improvement, and then things get worse. I'm going to break here for a second. When he came to New York and he came in my office, I had a conversation with him that I have too often. It feels like almost every day. I think it's a conversation that very few doctors in Israel have with their patients. I think it's a reflection of cultural differences between the way things are done in the US, at least the way things are done at a large cancer center. And I told him and his dad I could not cure his cancer, that they needed to know that, and that if they felt that under those circumstances, hearing it for themselves in my office, they wanted to go back to Israel, I would understand that. But they shouldn't have unrealistic expectations, that the best that I could do was give him more time. And if that was good enough for him, then he and I were going to become partners. And he was going to tell me how sick I could make him or not to try to give him more time. And he was very clear. He was very active, and the most important thing for him at that point in time was for his back pain to go away so he could start playing soccer again with his friends. The chemotherapy allowed him to do that, and it gave him 4 months of spectacular quality of life before his cancer got worse. He sat down in my office and he said, what else can you give me? And we had the same conversation. How sick are you willing to let me make you to give you more time? So we picked the second chemotherapy regimen with a little bit more toxicity, but again, it worked for a couple of months and things got worse. So we gave him a third chemotherapy regimen, but by that time, a clinical trial had opened up. And it's really important when you hear the word clinical trial that you understand what we mean when we talk about that, because there are different kinds of clinical trials. There are clinical trials of drugs that we have absolutely no information about whether or not it works against any type of cancer. And the primary objective is to find out how much of a drug you can give safely. Not will it work, not will it make the cancer better. That's icing on the cake if it does that. The primary objective is, will you kill the patient, or can you give the drug safely? And if you can give the drug safely, how high can you escalate the dose before you have to stop? But for this young man, it was important to try to qualify for the clinical trial, even though he understood that the primary objective was to figure out how much of the drug we could give. So we gave him the Doxil, it didn't work. We gave him a cycle of standard chemotherapy plus a type of radiosurgery to his spine to try to get him to qualify for the clinical trial, because that was what was important to him. He did. He enrolled on the clinical trial, and his cancer got rapidly worse. But he went into it with the understanding that while we would pray for a miracle, that was not the primary objective of that drug trial. We gave him another cycle of the same chemotherapy with more radiosurgery to his upper spine, and again his cancer got worse. And all throughout this time, he and I had some very grown-up conversations. He was a kid, but we had some very grown-up conversations. And he made me promise him that when we got to the point in time where I had nothing else to give him other than myself, I had no other treatment to give him, that I would let him know that, because it was important to him to die here in Israel. He didn't want to die in New York. We had that conversation just after the 4th of July. He went home, and he died at home in Binyamina on September 6th. This is going to the airport to go back to Israel to die. This is not someone who looks morose and grief-stricken, because he really, really lived every day of his life to the fullest. And to this family, although if you asked me, was it of benefit for him to come and live in New York for 10 months, I would say no. He could have gotten the same treatment if he had stayed in Israel. When he left my office, he and his father told me they would make the same exact decision again. So was it of benefit? Depends on whose perspective you ask, right? And now the last case, and this story is an ongoing one. This is a wonderful 22-year-old with osteosarcoma, a type of bone cancer, that had come back for the second time. So he had been diagnosed at the age of 17 with osteosarcoma in one part of the body. He received exactly the same treatment here in Israel that he would have gotten in the United States, in New York. His tumor was exquisitely sensitive to chemotherapy. So when we treat kids with osteosarcoma, there's actually no benefit of giving preoperative chemotherapy, but we do it for historical reasons, because in the early days of chemotherapy administration, when the possibility of saving a leg became an option instead of doing amputations, it took 10 weeks for the prosthetic manufacturer to make a prosthesis for the patient. And so the surgeons said to their oncology colleagues, instead of wasting time and doing nothing, why don't you go ahead and give chemotherapy while I'm waiting for the prosthesis? And then we would have Friday morning tumor boards, and the pathologist would show us the specimen that had been removed. And the head of our pathology group, Andy Huvos, said, you know, it's really fascinating. Some of these kids, after 10 weeks of chemo, their tumor is completely dead. Others, it looks like they didn't get anything. Wouldn't it be interesting if we tried to figure out whether there was any difference in how they did after surgery based on what we see? And in fact, there is. The chances of a patient like this, whose tumor is essentially completely dead after 10 weeks of chemotherapy, doing well is spectacular. 85 to 90% of patients like this will survive their disease. The problem is that tumors don't read the textbook. And in December of 2020, a kid whose chance of relapse was at most 15% had a relapse of his cancer in his left lung. It was surgically removed, and quite properly, just as we would have done, no additional treatment was given. In March of 2023, his cancer came back again. This time in 2 spots, and this time surgery was not possible, at least according to the opinion of the doctors in Israel. His family came to New York for consultation. Our surgeons agreed that surgery was not possible. And so I offered him treatment that he could just as easily have gotten in Israel as in New York, and it didn't work. At this point in time, though, we had begun to have some experience with a combination of medications, probably over the prior 24 months, where we used an oral biological drug in combination with an immunotherapy drug. By itself, the immunotherapy drug never works against osteosarcoma. Not occasionally, it never works against osteosarcoma. And we started to see some patients whose cancer got dramatically better, in one instance for 18 months, and these are kids, all of whom had had multiple chemotherapy regimens. Unfortunately, Merck pulled their support for this clinical trial, and so the clinical trial closed, but now you have this information that there's a combination of drugs, commercially available drugs, which may offer some hope to kids with osteosarcoma. But I don't have a clinical trial anymore. What I do have are bulldog nurse practitioners who go to war every day with insurance companies. And when they say no, they say F you, and they appeal it. And when they deny the appeal, they say F you again, and they win. And we were able to get authorization for both medications. First set of follow-up scans on August 1st showed that the cancer was better, but still not better enough for surgery to be done. The second set of follow-up scans showed a discrepancy. The bigger mass, the one that was not surgically resectable in March or in May or in August, had gotten so much smaller that it could now undergo surgery. The smaller tumor had gotten bigger. We did surgery. I didn't do it. My surgical colleagues did it, and took out both tumors. He resumed treatment. His scans, thank God, have remained clear. Another set of scans will be done next week. We don't know how to explain what we saw under the microscope. The bigger tumor, the one that wasn't surgically removable until October, was completely dead. There was no healthy osteosarcoma. The smaller tumor, which had never been the bigger problem, showed mostly viable osteosarcoma. Of course, it's our hope and prayer that anything that might be left will be controlled by the continuation of this treatment. He is. And here's, I think, the best part of this. The best part is that he's well, and he's in Los Angeles having the time of his life right now. But he has a wonderful doctor here in Israel. And I spoke with his doctor, who said, yeah, we'll try to get Kupat Cholim to pay for the drug in Israel, and if they will, I'll continue it. Because to him it was important to try to get back to Israel if he could. And so he, in fact, returned to Israel and is continuing the treatment here. And God willing, when I see him next week, he'll have another clean set of scans. So 4 patients, 4 dilemmas. How do you define hope? How do you measure benefit? And most importantly, who gets to decide? I think we can all agree that an infant with a rare sarcoma that progressed on standard therapy benefits from consultation at a large cancer center. I think we can all agree that a teenager with a very rare sarcoma, where there might be only 1 or 2 cases a year in an entire country, where there may not be the expertise in even looking at it under the microscope or how to manage it, who might have a surgical option available to her, not available here, benefits from consultation at a large cancer center. I don't know. I don't know. In my bones, I don't know. As a young adult with a recurrent incurable cancer, is he benefited from relocating, moving to New York City and pursuing treatment that is not going to cure him, but is given in a very different environment? None of you should ever need to come see me in New York City. But being treated at Sloan Kettering is very different than being treated at most other hospitals in New York, and is very different than being treated at most hospitals in Israel. And then there's the gray zone, a young adult with a recurrent, possibly curable, I don't know, cancer, who could have gotten the same chemotherapy in Israel, but because he was in New York, he had the opportunity to learn about a treatment that we were gaining experience with, we were able to offer him, and seems to have benefited him. These are the things that I think about. I joke that I'm up at 5 o'clock every morning, which is true, but the 4.5 to 5 hours that I try to sleep are really spent tossing and turning. I don't know the answers to these questions. I struggle with them. There's just me, and I'm blessed to work with wonderful colleagues. But in a world where there is infinite suffering and finite resources, which children with rare tumors benefit from coming to New York, whether from other states in the US or from around the world? Are there system or culture differences between the treatment that you get at a large cancer center in the US versus what are, even amongst the largest cancer centers, the largest treatment centers in Israel, really comparable to moderate or small-sized programs in the States? And are those differences of value even if the outcome is going to be the same? What to do if you're going to come? Don't just show up. So pediatric oncologists like to think of ourselves as the quarterback, right? So we help coordinate your child's care. If they need surgery, we get them to the surgeon. If they need radiation, we help facilitate the radiation consultation. I think that asking your doctor or your child's doctor to reach out and make contact, providing a current medical summary, making sure that all of the records that we need are available, planning to coordinate so that if surgery needs to be done, letting me know about it 3 or 4 weeks in advance allows me time to put things together. There are some kids that I take care of who from the day that they become a candidate for surgery until the day they can have surgery is 6 weeks. So if there's coordination of care and advanced planning, things invariably work much better than showing up in New York and saying, "We're here, when can you see us?" What to do when families are told, "Don't come, but do"? I think it really depends. There are some families who come in our office and are told, "We can't change the outcome. It's going to be the same." And they get furious. "What do you mean? They," I won't say who they are, "they said you could cure them. That's why we're here." I think setting realistic expectations is critical. We try very hard not to mislead families about what's possible. It doesn't mean that there shouldn't be hope. It doesn't mean that there shouldn't be prayer. But I think setting unrealistic expectations is not in anybody's interest. And finally, at the end of life, what do you do? Sometimes kids get too sick to go home. If you don't have those conversations, if someone doesn't say to you, "My priority is going home," sometimes threading that needle is very, very difficult. You don't want someone to get so sick that they can no longer get on an airplane and safely come home. On the other hand, you don't want to, quote, give up too soon. Having those conversations is very, very difficult. The thing that they take the most of is time, and time is the thing that I have the least of. So how to do that when you're having these kinds of conversations every day is something that I don't have the solution to. But we try to offer our services whenever we can, and we try to offer hope whenever we can. And to those families who have come from Israel and given me the privilege of caring for your children, I say thank you.